Hello everyone, I am Dr. Farid Jareen. As you can see, today's video is very special and very important. This video is about chronic kidney disease. So let's start. Understanding CKD. So we need to know the chronic kidney function first of all. First one is erythropoietin production, vitamin D activation, and phosphate excretion. These are very important chronic function of kidney. And if CKD occurs, erythropoietin production reduces, vitamin D activation reduces, and phosphate excretion obviously it will reduce. So what happen if this occurs? So because of erythropoietin production reduction, it will cause normocytic normochromic anemia. And because of vitamin D activation reduction, it will lead to calcium and phosphate reduction. And phosphate excretion is reduced. It means phosphaturia is not happening. Excess phosphate is not going out from the body. That's why phosphate level in the blood is very much high in CKD. So let's talk about the pathophysiology of CKD. So as we see vitamin D activation, calcium, phosphate. So what is the scenario? In vitamin D activation, as we know, the vitamin D activation is reduced. So calcium is reduced, phosphate is reduced, and phosphate excretion is reduced. So what happens? Phosphate is increased. It means blood phosphate level is increased, and because phosphate is reduced and reduced because of vitamin D activation, but phosphate excretion is not occurring that much. So excess phosphate remain in the blood. That's why the end result is calcium reduced and phosphate is increased, and this is very harmful for the body. So here let's see the more detailed scenario. Here you can see, as we see in the previous slide, calcium is reduced, phosphate is high, and this will result secondary hyperparathyroidism, and this will lead to tertiary hyperparathyroidism because there will hyperparathyroid gland is enlarged, and it will try to compensate the calcium level. It will be normal or increased, and phosphate level is becoming increased more and more, and this will lead to osteolytic fibrosis cystica. This is a clinical presentation of CKD, and another thing is osteomalacia. So let's see the final thing we found from the pathophysiology, that is osteomalacia. It's a clinical presentation of CKD as we discussed in the scenario. And dynamic bone disease is occurring because of high excess vitamin D and calcium treatment because of osteomalacia, osteolytis, fibrosis cystica, and osteoporosis, and it will lead to a renal osteodystrophy. So these are the clinical presentation of CKD. This is occurring, osteomalacia is occurring because of vitamin D and calcium reduction, and when we treat the bone, uh, when the calcium is reduced, we give more and more vitamin, more calcium, and when it is become excess, bone become confused and system, it will lead to adenemic bone disease. So what is going to be the treatment? So let's talk about the treatment. Treatment is basically vitamin D and calcium supplements, phosphate binders, which can be calcium based or non calcium based, And there is an example of non-calcium based binder, phosphate binder, that is sevelamer, and parathyroidectomy. So why this treatment? Because vitamin D and calcium is a treatment of it is treatment when calcium and phosphate level is reduced, vitamin D is reduced, so we are giving vitamin D and calcium supplements. But when we are giving excess amount of vitamin D and calcium, this will causing this will cause adenomic bone disease. And in some cases we see calcium is reduced but phosphate is high, so in this case we give phosphate binders so that we can control the excess phosphate. And parathyroidectomy is should be done when uh, other treatments are not working, and if we see the evidence of hyperplasia in the parathyroid gland, and which is resulting more phosphate, and phosphate is not coming out from the urine, so that's why we do the parathyroidectomy.
Hey guys, if you enjoyed this video, do not forget to give a thumbs up and press the bell icon, subscribe to this channel, and see you in the next one. Bye.